And this is Interface. Welcome to it. I'm your host, Thembi Samachele. Is the cost of private healthcare too high in South Africa? The Minister of Health, Dr. Aaron Motsoaledi, seems to think so. Civil society, the private healthcare industry, and the community have been called to make submissions to the Health Market Inquiry to determine whether or not this is true. Let's take a look at some of the submissions made at the Health Market Inquiry.
In 2002, the total expenditure of private healthcare was 42 billion. In 2014, it was 140 billion. It increased by more than 300% in a decade. And if it goes like that, in another decade, it will be 500 billion. Nobody's asking a question about that. You're asking a question about NHI, which is still coming. Not about the system that you are faced with, which is escalating right in front of your eyes. And that system is saving only 16% of the population.
Providers of private healthcare have to relook at their business models. At the moment, it's a quick buck for many of them, a quick buck for the hospitals. They get a lot of money, they ship it out of the country.
Their prescribed minimum benefits are a list of 270 chronic and serious illnesses, which all medical aid schemes have to provide a minimum cover by law. Unfortunately, in many cases, the medical practitioners do not disclose to the patient that the illness is a prescribed minimum benefit, and neither do the medical scheme.
Well, let's welcome to join us in this discussion a representative from the World Health Organization, Dr. Sarah Barber, and also Thembekile Paswana, who is the Senior Manager at the Council for Medical Aid Schemes. And of course, if you would like to join in the discussion, you're more than welcome to do so. You can find us on social media, on Facebook at Interface on SABC, or on Twitter at Thembi Samachele or at Interface on SABC. And of course, we'll be taking some of those thoughts a little later on the program. Thank you very much to both of you. Welcome to the program.
Thank you. Thanks for having us.
So Dr. Aaron Motsoaledi, who was speaking very passionately there on that clip, was with us in studio about 2 weeks or so ago, and he was saying that he personally pays about 14,000 Rand for his medical aid, 14,000 Rand. And by November of every year, it's finished. So why are we in this situation? How did we get here, Thembekile?
Medical schemes increase every year. And what is also important is that consumers or members of medical schemes must choose the option that suits their needs, meaning that you must look at your affordability, first thing. The second thing, what is it that you're purchasing for? If you're choosing the top of the range benefit option depending on your healthcare needs, if you've got chronic conditions, then you need to go for an option that will suitably cover your family, so that should there be any healthcare events that needs cover, you know that you're guaranteed for cover by medical schemes.
I understand all of that, but why is it so expensive in a country with so much healthcare needs and just only 17% of the population that can barely afford what you guys are charging?
The charges are determined by the medical schemes themselves. Council for a medical scheme that doesn't set the prices. It's medical schemes that submits the prices to the regulator. The regulator then sees whether are those contributions affordable or not.
But what's
you find
your
that in some
there?
Instances where we are of the opinion that there's no justification for a medical scheme to charge a particular amount of number or to increase by a certain percentage, then a recommendation is sent through to that medical scheme for them to review that particular contribution. So it basically most depends on what they've submitted to the offers. And remember, there are also other cost drivers. You find that if those medical schemes have paid so much due to the utilization that is expended by those members, therefore it will justify them paying higher contributions.
I'm more interested in what you as a council are doing to try and deal with what is very clearly an unsustainable situation in our country. So I'll give you a moment to think about that while we bring Dr. Sarah Barber into this conversation. Exorbitant amounts being paid for healthcare in South Africa, private healthcare. Tell us a little bit about the study that you were involved in.
The study that we commissioned from the OECD, the Organization for Economic Cooperation and Development, looked at prices of private hospitals in South Africa in comparison with OECD countries. And we made a few conclusions from this study. The first, that prices are high. The price levels are on par with countries with much higher income levels, France, Germany, UK. This is the price level that's existing in South Africa. we found that also that the prices are increasing very rapidly over time.
I want to talk about that, but I just want to quote something from that very study. You say private hospital prices are expensive even for individuals with high incomes. So it's not to say that, you know, they're okay, they're expensive for people that are poor and can't afford it. They're just expensive, period, for everybody.
That's right. We looked at an affordability analysis. So we compared the hospital price levels with the price levels for general goods and services in the economy in South Africa. And we found that hospitals are charging high prices in an environment where other services are being delivered at a much lower cost.
How did that happen, though? How do we get to a position like that where we are being charged almost the same, if not the same, as somebody that's sitting somewhere in the UK or somewhere in the US?
If I can bring the South African context, at the moment we don't have a price setting mechanism. There's no one who regulates what is it that the doctors are supposed to charge, as well as hospitals. At the moment, it's a free for all. What we've done as a Council for Medical Schemes, we look at the data that is submitted by medical schemes. In our statutory return data, we're able to pick up how much exactly have they charged, and then we're able to do a graph to come up with who is expensive among all the role players in the industry. The studies show that hospitals were paid 37% out of the whole pie, which was followed by specialists. So you could see those two are the one followed by medicines. Those three, in fact, are the ones who have charged higher over and above other service providers that are in the industry. So clearly, due to this lack of price setting mechanism, members are vulnerable at the moment. Patients, if you land up in hospital, in most instances, you don't have an opportunity to discuss the rates with your service provider. It's only after you're discharged where you then get a bill from the hospital. Then it's only then where you see whether has the medical scheme funded that bill in full or not. So it's because of that particular gap. So it's very important that something must be done, because at the moment, due to that lack in the industry, you find that doctors charge whatever, then you and I are vulnerable. So it's very important for the Minister of Health to come up with some mechanisms just to draw a framework.
Let's talk about that. The Minister is well documented as saying he's been trying to get the industry to cooperate. But every time he touches this, because it means, you know, it affects the money going into people's pockets, you know, they fight him. What would you do if you were the minister? And what would you suggest that he does now that he is the minister right now?
That's difficult to say, but certainly we have a lot of hope in the Competition Commission's inquiry into the private sector. So the private healthcare sector, this inquiry was established to look at this very issue. Are prices too high? What are the costs? What's driving these high prices? And what needs to be done about it? So we do have a hope that the Competition Commission will respond to these issues and come up with recommendations to redress the problem.
What's being done in other OECD countries? How have they dealt with something like this?
In most OECD countries, you do have a mechanism for price regulation. You have a system, a technical system, whereby you try to establish what a service actually costs, and this is then used as the basis for negotiating fees with providers, whether through public facilities or private facilities. This is a mechanism that is lacking in South Africa.
Is it a trust issue, do you think, where people are saying, you know what, I so do not trust the public healthcare system that whatever they charge me in the private healthcare industry, I'll pay it because I don't want to end up in a public hospital?
It depends who you speak to, because not all is bad in the public health sector. There are pockets of excellence in the public health sector. And remember, those service providers that end up in the private sector started with the public sector. They started there and they are continuing teaching other doctors that are in the public sector. So it depends who you speak to. Other people don't want to go to the public sector. We know the problems that the public sector is having at the moment. Under resources, that's staff shortages, lack of facilities, stuff like that, emergency, people who wait hours on end in the queue. It could be those are the reasons others don't trust the system under those circumstances. But I think there's also faith. Both systems can work. It just depends who you speak to.
All right, we would love to hear what you think on this discussion. Give us your thoughts on social media, Facebook and Twitter. We're back after this. Dr. Sarah Barber is with the World Health Organization, and they commissioned a study looking into the price of healthcare, private healthcare in South Africa. And we are also joined by Tembegile Paswane, who's a senior manager at the Council for Medical Schemes. Now, before the break, we're talking about just how expensive things are. Let me give you some of the thoughts that you've sent to us on Facebook. Ria van Sale says, for the first time, the study shows that we as ordinary South Africans, what we have known in our hearts for a long time, but we didn't have the proof, that private healthcare is expensive. We feel it in our pockets every month, and we need prices to be set as it happens in other countries. So we can tell when we are being ripped off. And then Leonard Paul van Donner says, it's private healthcare. Those who throw money at their health insurance are free to be milked. And Teresia Malumane says, I wonder if the Minister of Health, Dr. Aaron Motsoaledi, has thought about private health care not receiving subsidies from the government and his department. They have to make money themselves to pay staff, expensive equipment that public hospitals do not have. Has he ever thought about the motivation behind the real salary increases? So some of the thoughts coming through, and we love reading them. Do keep them coming, and we'll see how many others we can squeeze in throughout the show. So let's look at that second one from Leonard van Donner, Sarah, because he says it's private healthcare. If you want to go and throw your money over there, do it. And if they milk you, so be it.
Healthcare is a public good. The health of one person impacts the economy as a whole, it impacts other people, it impacts the community. We need good health to drive the economy. So healthcare is important, and it's a public policy issue.
Yeah. So why is it that in some of the other OECD countries that you looked at in your study, most people actually use public healthcare and then use private healthcare to bridge the gap, whatever shortage there is there? They're quite happy to do that, but in South Africa it doesn't seem to be the case.
South Africa is unique. South Africa spends 42% of its total health expenditures on private voluntary health insurance that serves only 16% of the population. So it's quite a unique system, South Africa as well as some of the countries in Southern Africa region, because of the history of this duplicate health service system. We have seen in other countries, particularly countries in Europe where, or even in the US, where you have an overall reform process, there's an effort to try to guide the private healthcare sector to be able to work together to achieve access to health services for the whole population.
Is the NHI the solution? Is that what's going to sort this out for us?
It could be, though at this stage, remember, we're not aware of the actual package that will be seen in NHI. At the moment, it's just papers where public is allowed to comment, and the minister has extended that period within which to comment. Now, once we can see the package, then we'll be able to tell whether. But what we see is that it will be complementary, the medical schemes now, to NHI, because what the Department of Health is envisaging is a situation whereby most South Africans which cannot afford to belong to medical schemes are covered in the public health sector. That's why you see what they are doing at the moment. They are district hospital where they are revamping staff capacity, they are improving on that so as to just to improve the services at that particular front. So it could be a solution for South Africans in the years to come. And remember, once it starts kicking in, it will be baby steps. South Africans mustn't expect that everything will be running smoothly. So we must give NHI some time for it to run fully in operation, and then we'll make a decision then to see whether it's working or not.
Your thoughts on this one?
I agree. I think NHI provides a framework to move ahead. It won't happen overnight, and the Department of Health has said that NHI will be implemented over a series of 14, 15 years. But we need to go step by step.
But is it the right option for us at this time to deal particularly with the issue of high costs?
Well, under an NHI-type system, which aims to achieve universal health coverage, essentially, we have the framework under which we can determine where the private sector fits. So will the private sector provide complementary services? Will they offer supplementary services? Will they be contracted to deliver some basic services or specialist services? So yes, we need that framework. And then the next step is then looking at the price schedule to be able to contract the private sector to expand the reach of the public health system. We need a system of regulation. We need the system where we determine how much things cost.
So in the study you say, given that South Africa has the lowest GDP per capita relative to other OECD countries, one would expect hospital price levels in South Africa to be significantly lower in comparison with OECD averages. However, South Africa is an exception to this. That is surely unsustainable.
That's right.
Now, when we talk about any of this, the private sector fights back and pushes back, and they say, no, this is not the way to go. What is it that we need to start doing now to try and prevent the bottom from falling out at some point, just because this is not sustainable?
We need to establish this framework under which the private sector can work together to achieve our goals as a nation, the South African people, to serve the people and to deliver quality health services.
If that's going to hit people's pockets, it's not enough to just say, well, we'll have a framework and we'll be nice about it and ask you really, really nicely to cooperate. How do we make this stick? How do we make sure that your people in the medical aid schemes, the doctors and other practitioners, actually come to the party and they play ball?
I think what we need to wait for is just the outcome of the Competition Commission health market inquiry. Then the recommendations will be there, which will tell us what exactly that we need to do as a country, because clearly South Africans need to be provided to get quality healthcare at the end of the day. So we can't wait for the report to be out, so that at least it will give a guidance as to what is it that we need to do as South African citizens, because currently we know that the public sector is overburdened. And there's an epidemic, you know, the burden of disease in South Africa is high. You find that the public sector doesn't cope, and at the same time, if people go to the private sector, it's expensive and it's unaffordable. So there must be that gap. So we can't wait then for the outcome and the report by the Competition Commission.
What are the implications of what's happening here? I mean, right now, it is the way it is. You know, it is expensive, 17% of the population being serviced by the private healthcare industry. What does that mean for a country like ours with the challenges that we're facing?
Private voluntary health insurance consumes 3.7% of total GDP, so it's an enormous amount of the economy in South Africa. It also impacts the public sector. For example, under NHI, we need to expand on health services. Most of the specialists, many other healthcare professionals are working within the private sector, so there does need to be a mechanism by which we can work together to achieve universal health coverage. And in the end, as you're saying, the individuals suffer. Higher prices and increasing prices are passed on as higher premiums, which are then borne by the employers and the members themselves, and can result, for example, in higher co-payments, reduced benefit packages. So people are suffering under this current system.
That's right. Even if you are the Minister of Health and you're paying 14,000 Rand for your medical aid, it's still unaffordable. Well, we're going to take another short break. We're back after this. And we are wrapping up our conversation around the cost of private healthcare in South Africa. Give us your experiences as well. I mean, you've got a medical aid maybe, and if you do, what has been your experience? How much are you paying, and how much do you think you should be paying, considering what's going on in the country? And you can always drop us your thoughts on Facebook at Interface on SABC, or on Twitter at Tembisa Magele, or at Interface on SABC. So the cost drivers that you talked about earlier, for this, are they universal? Are they the same in other parts of the world, or is it just peculiar to South Africa?
There are many similarities between what's happening in South Africa and some other parts of the world. We found in our study, for example, and similar to what was discussed earlier, that the hospital component of the price is enormous. It's 40, in our study we found that it was 40 to 62% of the total price. Most of the insurance packages in South Africa are hospital-based care, and we know that hospital-based care is an inefficient and costly way of delivering health care. A better way is to look not at the hospital-centered system, but a system that's centered on the primary health care model with the GP at the center, so that we can have care closer to the people and respond better to the people's needs, people's health needs.
So if the Competition Commission finished what they are doing, and Minister of Health came out and said, look, we've got to start capping fees at a certain point, would you and your members be in favor of that, or in support at least?
Yes, especially when it comes to charges. charges by service providers, that is hospitals, specialists, there are allegations that they are exorbitant. And in our study, we say that yes, those are the two highest, charges that are made. Then we'll be glad if they say that reduce some costs, then if it can start there. And some technology as well, you find that the technology that is introduced, new technology, is expensive. You find that now the doctors will stop using the old technology and come up with a new one. But what is important, we need to find out if now they are changing this technology and now they are introducing something that is expensive, then is it efficient for them to do that? If maybe it will reduce the length of stay, I'll improve much better, then let it be. But there must be that balance. Don't just jump to use a new technology, at our expense. And also the non-healthcare expenditure, we are very concerned about. You find that in the medical schemes industry, the chunk of money goes to the administration. Yeah. Those companies that administer the medical schemes, they are paid billions and billions of amount. Managed healthcare companies, as well as brokers, if those fees can come down, because it doesn't help everybody in the system, those non-healthcare costs must come down.
But are you educating your members around things like minimum benefits and other things?
Yes, we do. We've got a department that deals with that. Like, I'm here now, where it's part of the education to consumers, where they need to know. But what is also important is that medical schemes do send out brochures or summary of benefits. Members have an obligation to go through the brochure so that they can understand exactly what is it that they are covered for.
But isn't that like, me walking into a shop, buying a shirt and walking out and finding out that this shirt is of a lower quality? And then you saying to me, well, you should have checked the quality of this shirt instead of, just buying it off the rack. Shouldn't the responsibility be on the person that sold me the shirt to make sure that it was a higher quality?
It is. It is a responsibility for a medical scheme. What we've recommended for medical scheme to do is that the information that they are sending to their members must be written in a simple and understandable language. They must stay away from using medical jargon, because the member needs to understand exactly the nature and extent of benefits that they've purchased, so that at the end of the day they make an informed decision whether they purchase this particular option or not.
Private healthcare is very lucrative at the moment. If you are a specialist, especially, I love that, specialist especially, it becomes really, really good for you. If there is some kind of intervention, price capping, will that not drive doctors away to other parts of the world?
I don't think so. I mean, most other parts of the world already have this kind of a mechanism in place to control prices or to establish the actual price based on the service that needs to be delivered. So I think that South Africa is unique in this aspect, that it does not have this kind of a price regulation. And specialists would find that it is in place in other settings.
Do you think that if there was such a thing, that some of the doctors would actually be more keen to go and give their skills or apply their trade in the public healthcare sector?
We would hope so, yes.
Do you think it would happen, some of your members?
Yeah, and remember, some of the doctors are actually coming to South Africa to render their services to South Africa. So others are leaving, others are coming in. So it's, again, personal preference.
Let's look a little bit at what the last person in our Facebook messages that we read earlier had to say. Teresia Malamule says, Dr. Aaron Motsoaledi has not thought about subsidizing the industry, and that the reason why healthcare costs are so high is because they're not subsidized. Sounds like a fair argument.
Well, there is money going into medical scheme premiums. There's support to premiums of certain members, GEMS, government employees. So perhaps you can speak to that better than me.
Yeah, most government employees are subsidized. So.
But the non-government employees, the people that work for private companies?
Private companies, some, it depends on the company that you belong to, of course. And again, it will be a relationship between you and your employer. If the part of the benefits are like you get medical aid subsidy, then you'll be subsidized. But so it's not true that the Minister of Health failed to look into the issue of subsidy, because most government employees, and if you belong to GEMS, you subsidize. But if you move out of GEMS, because GEMS, remember, it's a government employees medical scheme. So the intention is for all government employees to belong to that particular medical scheme, just to pull the risk to that particular industry.
I think an important issue is that costs are increasing above the rate of inflation, and so we can't just continue to accept this and say, well, somebody has to pay, somebody has to subsidize. We really do need to look at what those cost drivers are to try to get the costs under control, because it's simply, as you mentioned at the beginning, an unsustainable situation.
What can we as consumers do? What's our pushback?
It's depend on the rules of medical scheme. If you belong to a medical scheme, try to limit the exposure to the risk. If the rules of a medical scheme has selected a number of service providers that you need to go to, it's called designated service provider. Go to those designated service providers, because there won't be any co-payment that you'll be liable for. But if a member opts to opt out of the system and chooses a doctor that is not part of the network, then they're exposing themselves to that financial risk. And you don't have to turn around and blame the medical scheme because you needed to play by the book. They informed you where to go, you decided to do the opposite. Then you'll be liable for the difference.
Final words from you?
In other countries, consumers demand more information. More information about prices, more information about quality. We can't assume that higher prices equal higher quality. So I think that we really do need to know what the quality of the services are so that people can make informed choices.
Thank you very much, ladies. We're going to have to leave it there. Thank you for coming through to talk to us on this topic. And of course, I am hoping that we can continue it on social media and also get your thoughts on how we can assist the minister to try and get this one sorted for our benefit. And that's how we come to the end of our program this week. Join us again next week at the same time. Goodbye.